بسم الله الرحمن الرحيم. نبدأ because I know it is quite late عندكم في بعض البلدان العربية، لكن these days we are busy here as well, and I have to try to squeeze it after the working hours. أنا للناس اللي هم ما تابعوش معنا قبل كده، I am a consultant general pathologist with some interest in certain areas. I work in the United Kingdom in Essex at the moment, and basically what I try to do, and Dr. Omar and Dr. Fatma or Dr. myself, what we try to do here is in this group iHistopathology is that we try to share with you what we've learned in the United Kingdom during our training and throughout our day-to-day practice. بالنسبة طبعا للناس المشتركة معنا النهاردة، أو أهلا وسهلا بكم جميعا. I just want to say that we have a different levels. Some people are just started. Some people has been just very early in practice, in training. فبالتالي we have to taper the level according to everyone. فبالنسبة للناس اللي هم very experienced, sometimes you might not benefit a lot from this, but it might just give you an idea about the difference between practice in your lab and the practice in the United Kingdom, so you can tailor your practice accordingly. يعني هي دي تكون ممكن استفادة بالنسبة للناس اللي عندهم خبرة. طبعا في ناس يعني خبرتهم تتوزن بالذهب، وأكثر مني خبرة كتير النهارده متواجدين معانا يعني. فطبعا all my respect to you all, and as I said, this is going to be a limited series. I'm not sure if we'll finish it in 2 or 3, but this is a limited series. It's not like the soft tissue, the liver. I know the soft tissue we will restart it on the advanced level now لأن احنا finished the basics. لكن we will do the advanced soft tissue very soon, I think in the next week or later on during the week here. So we will decide on this inshallah. Okay, you probably agree with me that the GI biopsy, it is the easiest biopsy. Do we agree on this, or we don't agree? So just tell me your thoughts if you agree or not, because I think it is the easiest because everyone is doing it. ولما يكون كل واحد حاطط ايده في الطبق عشان ياكل منه يبقى معناه ان الاكل طعمه حلو. فبالتالي يعني everyone is doing it. No one say no for it. فبالتالي it must be يعني it must be a very easy things. الدكتورة رحاب, I think everyone can hear, so you may have muted on your line, and I will let you guys to reply to the people on the chat room, so I won't reply anymore. Yes, but it's the truth, isn't it, that everyone is doing it, and this is probably the problem that makes the gastric biopsies, the lower GI biopsies for colitis a little bit confusing, لأن كل واحد يعني بيسويها بطريقة اللي تعجبه. And then this is just an example of causes. Of course, I didn't put the drug-induced here, but in drug-induced colitis is a big one. But one of the things that also confusing is that there's a lot of conditions that can be diagnosed out of these biopsies, and there is a lot of overlap, right? So this is number 2 in terms of confusion. So number 1, that everyone is trying to do it, either they know or they don't know, they still wanted to do it. And the second thing, that there is a lot of overlap between all of these different diagnoses that you can see on the screen, including of course the drug induced. النقطة الثانية, I think الصعوبة في الcolitis in general, that it is like a building. You have to build the case, right? So it is not like 1 زائد 1 بيساوي 2. It doesn't work that way. You have to use a lot of symptoms, a lot of things that you have to look into it from all the way around in every fragment, in every area that has been biopsied, and then you will be able to basically make a diagnosis. But there is a lot of them. You see, there is a lot of features that you have to carefully, and I mean the word carefully, assess, and then you will be able to come with a diagnosis. هو أنا دايما لما يجي لي حالة colitis أو suspected colitis دايما يعني أسيبها الوقت أنا أكون I can dedicate يمكن sometimes لو جات لي serial biopsies من terminal ileum لغاية الrectum, what I do, I have to assess them when I have the time to. So sometimes if I am rushing أو عندي مثلا ضغط في الشغل بسيبها لغاية وقت فعلا أكون أنا عندي وقت. ليه؟ لأن sometimes these cases might take 30 up to 30 minutes, so by what you will have to type it or dictate it, and this will take another 6 or 7 minutes, so it can take a long time. لكن you have to assess every one of those separately in every focus of the biopsy fragment. وusually في العادة بيكون مثلا جاي لك 4-5 من الاليوم، 4-5 من السيكم، 3-4 من 3-4 fragments من ascending colon, transverse colon وهكذا. فبالتالي you have to be very careful in assessing those, because otherwise you will miss. You see, you cannot just look at it and say, oh, I know what it is. فبالتالي what I find out that people tends to form a general idea and then they try to come up with a diagnosis, right? And these are common diagnoses that I see it for a lot of practices. Yani, I see in a lot of practices, sometimes people give a diagnosis of chronic colitis, chronic active colitis, non-specific inflammation. Wow, non-specific inflammation is one of the very common بالنسبة يعني للgeneral pathologist. They love that, which is it's completely and utterly meaningless, and it doesn't really follow any pattern. يعني انت لو حضرتك اخذتي كل الكتب بتاعت الGI pathology and افتحي الchapters بتاعت الcolon and try to search for non-specific inflammations, you will not find it. على الرغم من كده, it is a common diagnosis. It's a common diagnosis that the general pathologist invents, لكن هو مش موجود في الكتب. المشكلة بالنسبة chronic active inflammation, however, it's a diagnosis that you can use, لكن you cannot use it on a follow-up biopsy. You see, the early or the first diagnosis, you can use it, لكن you don't use it without comments. فبالتالي لازم هنحط comments بعد الchronic active colitis نحاول نقرب الصورة شوية للclinicians. لكن في الfollow up, if you have a surveillance biopsies that's coming after 4 or 5 months now, then you cannot use that term, because if you continuing to use that term, you are not guiding the treatment for your patients. And then chronic colitis is really something that I don't tend to use, and if someone is to use it, it only means to me that you've diagnosed these patients with inflammatory bowel disease in the past, and now the patient has got what you call it quiescent colitis. لكن كلمة quiescent عشان خاطر it is difficult to spell, so you prefer to use the chronic colitis instead of quiescent colitis, okay? But this is basically what it means. لكن for me, it doesn't really means a lot in terms of cause. It doesn't identify any problems. لكن هي المشكلة بتيجي منين بقى؟ المشكلة إن ممكن يكون you have been trained by someone who's very good, but very cautious, right? So she or he they don't commit to a diagnosis على الرغم من they know it all, right? يعني هو مثلا تكوني حضرتك قاعدة مع البروفيسور وهو يقول لك yes I know this is ulcerative colitis لكن أنا بطبعي ما بحطش الulcerative colitis على الريبورت. ليه؟ خير إن شاء الله في إيه قصة يعني؟ وأنا ليه آخد المسؤولية بتاعت العيان ما يروحوا يشوفوا هم بالاندوسكوبي عنده ulcerative colitis ولا عنده جن أزرق هو تبع نفسه يعني. مش مشكلتي. وهو أنا I understand that this is a protective medicine. You see, you are trying to protect yourself. فبالتالي you don't try to commit for a diagnosis. لكن if you have a skin tumor, for example, you are trying to commit for a diagnosis. You will tell me it's a basal cell carcinoma. You will tell me it's a sebaceous carcinoma. لكن you are not going to tell me it is carcinoma and that's it. Yes? So you will try to commit. So what is the difference here? I don't understand what is the real difference and why then we bother to take clinicians, why the clinician bother to take the biopsy and send it to you, and why should the patient bother to pay you the money anyway? And if you are doing it even in private sector, why then we bother about loading the service with biopsies that you are not going to give a diagnosis for? فديت أحد النقط اللي هي بتعمل confusion. There are guidelines. We have in the United Kingdom, we have guidelines. This was published nearly about 8 or 9 years ago now, right? And the surprise is that a lot of people don't know about these guidelines, you see, either in the United Kingdom or outside, right? فأنا لما أشوف إذا كان في ناس كتيرة عندنا هنا في England, they don't know that there is a guidelines on how you report these cases, then I won't be surprised that some of you never heard of this. You can find it by if you just take a photo shot with your camera into these guidelines, you will find it. It is for free. You download it for free, right? But this is a very comprehensive guidelines on what you should look for and what you should report, how you should report your biopsy. And a lot of what I'm going to talk about in those couple of seminars or 3 seminars will be based on these guidelines, which a lot of people have never seen or have never read. The other things that you can have complementary, a lot of papers are present, but this is a very good review articles that's very, very comprehensive, really, really long, about 20-page long review. And it's better than a lot of book chapters that I have seen over the years. فبالتالي those are 2 starting, and every seminars will give you some more resources to look at. لكن هو الالتيميت الجزئيه اللي انا كنت بتكلم عنها من دقيقتين 3 that people don't like to use chronic active inflammation. لكن what is the guidelines that we in England we try to tell you that this is the diagnosis, this is a tree, just a very, very simple tree of how you will follow in order to diagnose the things of inflammatory bowel or other causes of colitis. Yes, so basically, if you think that IBD might be favored over other causes, so فبالتالي لو if you have an infectious colitis or drug-induced colitis in the differential diagnosis, then you can say which one do you favor. So you can tell me, oh, it might be infectious colitis, it might be inflammatory bowel disease, بس أنا favored شوية inflammatory bowel disease over the infectious colitis. Okay, fine. We accept this, and we will see when we will accept something like that. لكن guidelines من British Associations of Gastroenterology, it is basically targeting this. You need to know when you will say the ulcerative colitis is definite or very likely, when you would say ulcerative colitis favored over Crohn's, and when we will use the inflammatory bowel disease or undeterminate, we don't know, or when we will favor Crohn's over ulcerative, or when we are 100% certain that it is Crohn's disease. And I am talking about diagnosis on the biopsy. This is the British guidelines, and this is our practice in England. This is what we try to do. We try to give a name on these biopsies, and we have some degree of certainty. So sometimes we say one is favored over the other one, or we are very sure that this is what it is. So we don't just leave the clinicians, our gastroenterologist in the dark. ودايما بنحاول to reach the diagnosis, then we will guide treatment. مفيش داعي لتأخير التريتمنت لمجرد ان الباثولوجيست doesn't want to commit. وان احنا عارفين في بلادنا راح ينقعوا العيان في طشت انتي بايوتيك، وبعد كده هو هياخدوه غسيل ومكوى على الستيرويدز، وبعد كده صح، مش هو ده اللي هيحصل؟ اوكي، كل ده عشان كلها تجارب. اوكي، فبالتالي we have to try to commit, and this is the problem. You see, this is another problem why the clinician find the pathologist confusing. عشان خاطر احنا مدرسة اللي تخاف منه يبعد عنه، هي دي المدرسة اللي هي let's not commit, just it's an active colitis or chronic active colitis. اوكي، مفيش داعي نخش في سكة الالسراتيف كولايتس والكونز ديسيز ولا الخزعبلات الثانية. خلاص هي كده وتمشي اوكي، لا ما تمشيش. اوكي، وبعدين اوكي let me now try to tell you the ultimate point of confusion. Yes, what هي مسميات, right? What do we call it as an abnormal architecture or crypt distortion? Yes, so we have this abnormal architecture and crypt distortion, which is one of the ultimate features لأي chronic colitis. We know that it's a sign of chronicity, right? So whatever it is, either prolonged infection, either it is UC, Crohn's disease, or radiation, or ischemia, or whatever, it is a chronic process, and it is a sign of chronicity. And this is basically are the items that comes under what I will label it as a crypt distortion or architectural distortion. لكن أنا في الريبورت بتاعي لما أجي أعلق على الكريبت architectural distortion, of course أنا بعلق على degree of architectural distortion، إذا كانت هي mild مثلا أو subtle أو moderate أو marked أو severe. لكن في نفس الوقت أنا أعلق أقول which one I do have in this. ليه؟ لأن it makes a difference. And we will see in these seminars how the architectural distortion can make a real difference in deciding the cause of colitis. And these are the list, okay? More or less, these are most of them. So crypt branching, loss of parallelism, tortuosity and angulation, horizontal and oblique crypt alignment, dilatation, intercrypt variation in shape and size. And some people put crypt atrophy with the abnormal architecture. Some people like to leave it alone. It doesn't matter, right? Because it's still signifying a chronic crypt loss, isn't it? Yes, so this is crypt atrophy. Okay, لغاية هنا النقطة اللي جاية بقى هي why people then get confused if the story is that simple. لأن لما بشوف أنا ببص على المحاضرات العالمية في الكونفرنسز وفي العالم كله، هو وحتى يعني حتى اللوكال يعني اللوكال ليكتشرز والسيمينارز في workshops او inside a department interdepartmental meeting، هو احنا يعني بشوف دايما ببقى قاعد بلاقي الناس تقوم حاطه الليسته دي وساكته، اوكي، وتقوم تنقل على اللي بعدها، تنقل بقى على الانفلاميشن، تنقل على الميوسين ديبليشن، تنقل على كل يعني الفيتشرز الثانيه. اوكي خلاص اكتفينا؟ لا ما اكتفيناش. اوكي، وهو المشكله ان احنا ما يعني قريناهم لكن ما حاولناش نطبقهم ساعات. وهي ديت الفكره، ان ديت حاجه زي كده هو بتاخد وقت طويل. and you will understand why. You will understand why this biopsy should be taking a long time. I will start now by dissecting the idea of crypt branching, right? We are going really basic here. Yes. So for those who are late for bed and they don't want to go basics, go to bed now, right? For those who عايزين يكملوا السهرة يكملوا. Okay. خلينا بس نفكر في الكريبت برانشينج. Yes. Now then. Okay. النقطة الأساسية إن هو okay crypt branching. This is a crypt that's branched. Do we agree with this? Okay. I just wanted to make sure that you are going to see. I will start using a pen here, right? So this is a crypt that's branched. And what do you think? What is the view into something like this? Do you think that this is, you see that every day, isn't it? You see that every day in the biopsies. How serious do you take something like this, right? You might sometimes ignore it, right? So you might sometimes ignore this. And this is another one. Look, this is a crypt that has got a groove here in between. Yes? So that's a crypt as well that is branched. Then, but the rest of the crypts look okay, right? So my question to you then, if this is all what you find in your biopsy, would you call this crypt branching? Yes. Okay. So what is the verdict? What is the verdict here, right? So don't hesitate and don't be. We are all learning from each other here, right? So I wanted to know what people. Yes. So some people said no, and some people normal as an isolated findings. Some people said no. Okay, fine. Well, the people say it depends how many, right? How many of those did you see? Did you see one? Did you see two? Did you see 3, 4, 5? We love numbers in pathology, isn't it? We do love numbers, yes? I said there's no other features. Yes, I said that there are no other features for those who are asking for other features. I said if this was an isolated findings. You see, yes, in a number of 1 or 2, we will, and there is no other features, then we might ignore that. Okay, so we might ignore something like this, but I tend to mention it in my report. Okay, so I tend to mention it in my report, and I say there is subtle and occasional crypt branching present. This might indicate a regenerative process. لأن هو الcrypt branching, simple crypt branching like this, it indicates to me that there is a damage happens. لكن عبل ما العيان جالك وراح الاندوسكوبي وبلاد تجيبه وبلاد تحطه ويروح ويلاقي السيشن كان كانسلد والاسبوع اللي بعده تعالى وعبر ما يجي المهم يعني راح وكان خلاص اتعالج. خلاص خد الجرعه يعني التمام بتاعت الانتينال والانتي بايوتيك وكله كله، وبالتالي all what you will see is a regenerative process and that's it, right? So, but what the expert will tell you when you see something like this, just slow down, be careful 100% that you are not missing a focal activity in any other biopsy. Then you might get 1 or 2 crypts with a very subtle acute cryptitis, and that will give you a diagnosis of focal active colitis, which can happen with infection. It can happen with drugs and things. But when you see something like this, just yes, okay, in a completely normal biopsy, you will, but I will examine it carefully. Now, some of you, Dr. Arania, you said that in the rectum, you might consider it okay, acceptable. I think around the anorectal junction, okay, right? But we don't tend to judge a lot of architecture around the anorectal junction, right? So be careful when you mention the word rectum, because otherwise you will not accept any crypt architectural distortion in this. Yes, I am not saying that there isn't other features here. I'm just saying if there is no other features, what would you do? دلوقتي some of these some books and some papers will tell you, actually, if you see more than 5 in the same biopsy, like in the same region, then you should classify it as a subtle crypt architectural distortion, right? So the number then matters here, right? So I don't know why 5, why not 4, why not 6, but so the number that has been mentioned, that if you can accept up to 3, but if you see 5, then just be aware. So when you see something like this, then you will have to automatically start counting. So that's one of the things that I would wanted you to consider. Okay, and this is just to show you, yes, it is a crypt, it is a bifurcated crypt, but in isolation, it might not mean anything, and then we might completely ignore something like this, right? So another example, we are still in the crypt bifurcation, right? Into عارفين I just saying in the biopsy, Dr. Ayman, I just say in the biopsy, so don't commit to high power field. If you see in the biopsy fragment, لأن هي البيوبسي بيجي لك multiple fragments. So if you see in one of the biopsy fragments, 4 or 5, then just worry a little bit. This is another one. Okay, but the bifurcation هنا, it is happening very high. Can you see how high this is happening? It is happening very high. We don't tend to get a very high bifurcation here. So you just have to be careful if this is really a bifurcation, or some people like to call this innominate grooves, like a little bit of an indentations of crypts, and they tend to branch like this, as you can see. Like I will be very careful to call something like this a crypt bifurcation. But then I will show you a lot of varieties, yes, and then we will see what I am trying to where I'm trying to take you. So don't worry, I will show you a lot of examples. See, this one is a little bit different. لأن bifurcations is happening in the lower end. Can you see? So in the lower end, we have a little bit of bifurcation, but again, in isolation, I might just ignore this, or just if it is one crypt like that. And we tend to see some crypts in the normal biopsies that's looking like that. And some people consider it even as a normal variation of some of the crypts, because it's very close as well to the surface, and it's fine, okay? But in isolation is okay, right? So in isolation, we might accept something like that. as an isolated and subtle, and that's fine. So we won't commit for chronicity based on this. This is what I'm trying to tell you, that you have to try to see how much you will commit. Now this is another one, right? So this is now a different type of story here, because this script is now trying to do this, and then this, and then this, and this. Can you see? So it is like a primary and a secondary branching, a little bit of more complexity here into that crypt. So now I am worried. I'm very, very worried about that crypt here, because this is, for me, it's not usual for a crypt to start branching that extensively, and then, but alone, if this is again the only findings, I will be very skeptical. But this is, that's it, I will let it go if there's no other features at all of chronicity at all. So if this is my only and one only finding, I might leave it. However, this what I'm trying to say here into a case like this, if this case was a Crohn's disease. So دكتورة مريم دي إجابة للسؤال بتاعك اللي سألتيه. If this is a case of Crohn's disease, and what I see is only that, but I know in the background that it is Crohn's disease, this is what people tend to call it mild and focal architectural atypia. عشان كده في Crohn's disease, people tend to tell you you don't have a lot of architectural atypia in general in Crohn's disease, لكن you can miss it. You see, it's almost always there. You will have some mild crypt architectural distortion, لكن you will miss it in isolation, because your mind is not, this is not the picture that your mind is used to see, because it is very close to the surface, although it is slightly complex in branching, like you tend to try to ignore it and move on. That's fine. Like in Crohn's disease, sometimes this crypt branching might be the only architectural distortion that you might get, and if you don't know how to read it, then you might miss chronicity, which will lead to Crohn's disease. Now we're moving in the complexity of the crypt branching. You see this crypt now is branching everywhere. Look, it is at all levels. It's branching primary, secondary, and tertiary branching. This is an ultimate features of chronicity, and you don't tend to get this complex picture in infectious colitis, for example. حتى لو كان العيان يعني قاعد بياكل طول اليوم من الشارع وعنده gastroenteritis ملهاش حل بقاله 6 شهور بgastroenteritis, then you wouldn't see still that degree of complexity of a crypt. This crypt is very, very complex. It has got primary and secondary and tertiary branching, and all of those, this architecture, you tend to see it more with the UC or severe Crohn's disease, or you can see it, of course, sometimes in diversion colitis. What I mean that this is too complex. This is a proper branching. You see, this is not, ده مش مجرد لعب عيال زي اللي شفناه في أول سلايد وتاني سلايد وتالت سلايد. This here is a proper crypt branching. You cannot ignore. Now you can see now that this is another feature to tell you about the complexity of the crypt branching. Okay, this is, although it is divided into two, لكن later on at the extension of the crypt it's become 3. So this features on its own telling you that I am a very complex branching, because now I am doing a secondary branching. So that's my primary branching, and then this is my my secondary branching happening here. So it depends what is the layout of your biopsy, but you will be able to judge. So if you see something like this is, for me, a significant degree of branching. Still, I will be thinking of conicity here, right? So features of conicity is on top of my list now because of this architectural complexity. Okay, we will carry on, right? So this is a different one. Yes, so this is a different case. Here you can see branching here. You can see another branching here. You will start to get, this is like the simple one, which I said, if you get this in isolation alone, you might ignore it. But if you get it with a lot of inflammation and other features, for you, this is now a proper crypt branching. And I am not going to ignore this, right? لأن في other features present, inflammation, lamina propria, whatever. We will talk about the rest later. But I'm just focusing now on the crypt architectural distortion, and I'm only now focusing on the crypt branching. So again, yes, if I see this now with other symptoms, then I will consider this as a proper branching. Now, hyperplastic crypt. Hyperplastic crypt is usually will have a serrated cells because this is the hyperplastic means. Dr. Ayman, hyperplastic means that you get a serrated morphology in the crypt lining, and you get a little bit of a tortuous appearance. Hyperplastic crypts is a term that we only use in the solitary rectal ulcer. Yes, in the solitary rectal ulcers, we will use hyperplastic crypts, but it tends to be present with crypt atrophy. And then it is trying to compensate for the atrophy by the presence of hyperplastic crypt. But if you are talking about branching proper, these are all what I'm talking about here are examples of branching. So just be aware of the term hyperplastic crypts. We don't use it like in the stomach. We use the word hyperplastic crypts a lot, but in the lower GI we don't tend to use that a lot. Okay, this is okay. The first look into a biopsy like this, a lot of people don't see anything unusual, right? But the reality is that it isn't really normal, because in this field, what I have a crypt bifurcated here, and another one here with a little bud, and another one here, and another one here. Okay, so already that's too much in one area. Now, if this is an isolated findings and you didn't find anything else, okay, على الرغم من يعني بصيتي عليها 10 مرات وما لقيتيش أي focus of acute inflammation elsewhere, then these are regenerative features. It is post-infection basically, or post-injury, whatever it was. حتى ساعات بيكون العيان بلبع علبتين ibuprofen عشان كانت رجله وجعاه او ظهره وجعه، وبعد كده هو خلاص ظهره اتحسن فبطل، لكن جاله خلاص الكولايتس والابيسود وعدت، الفوكال اكتيف كولايتس جت وعدت. فساعات اللي يتبقى منها by the time العيان have the endoscopy, then you will get this bifurcated crypts or crypt budding. You are right. I said there is a crypt budding, but budding we don't use it separate. We tend to use it as under the synonymous of branching. You see, but yes, you are right. It's a little bit of a budding, but it is still branch because it has got also lumina. Okay, so if it was only a simple bud, without a lumen, that's fine, but this has got also a lumina, so that means that there is a branching here. But the thing is that you need to be aware of that the frequency here is worrying, and then I will not say this is a normal, but I will say this is a regenerative or biopsy with regenerative features, which can happen post-injury, either with drugs or infection. Yes, so this is basically might be the only finding in your biopsies, and the most common to be missed, right? So a lot of the normal biopsies, when it comes to us to review, it shows this crypt bifurcation in this format, and we know that it has been missed because it hasn't got the enough complexity, but it has got frequency, right? Like there's a lot of it in this field. You wouldn't accept this in a normal area or a normal field. يعني هريكم النهارده بالكريبت بايفوركيشن. مش هتخلصوا مني. خلينا بس نحاول نكمل شوفوا this another one. Look at this complexity. Okay, so I just wanted to show you in various views how the complexity of the branching can look like. This is a very complex branching, like to our normal eye, we might just let it go. You see, we might let it go and we might say, yeah, okay, but it is a crypt branching. This is an ultimate, again, features of chronicity, this complexity of branching. You can see some other branched crypts with abnormal shape, of course, like in this one, you shouldn't miss this because this is very complex. حوالي 5-6 اليومنا. This is definitely very complex in terms of branching. It's a sign of chronicity. And here, what do you think? Do we have anything to worry about? What any one of the viewers? Anything? What do you think? Do you think that this is a crypt branching? So this is my question basically on this. Do you think that this is a crypt branching? Here, that one that I highlighted. Okay, we don't know. You see, we don't know. Okay, I don't think it is because it's in the line of the crypt, and sometimes the crypts can just kink a little bit and then give you that appearance, but it is in the vertical line of the crypt, so I wouldn't commit to that one. Yes, I wanted usually to see it in a little bit in a different, like sitting next to each other, not vertical to each other. So for me, I wouldn't commit that this crypt is a crypt bifurcation. So try to also, when you assess the crypt bifurcation, to look into the direction. Where do you see the bifurcation? Because usually if it is in the same line of the crypt, you might just getting a crosscut of the crypt at different level. And it's the same crypt, but it is just coming up and down. And this is why you're seeing it as double lumina, or like the other one that I showed you in the previous example. But here you can see it is going in the correct directions, and therefore I will tend to ignore this and I will not consider it as a crypt branching. Here, that guy. Yes, so that guy, I will not consider it as that. So just to highlight this, here is to show you again. It looks ugly. There is a budding. The budding is a very important feature to us in chronic inflammatory bowel disease. If I see it, لو تحلفي لي على الميه تجمد ان هو العيان ما عندوش يعني chronic chronicity, I will tell you no, this is a proper budding, isn't it? This is a proper, and here is branching to 3. Basically, you can see that there is enough complexity here in terms of branching to tell me, and that budding, just be careful with it. Just be careful with the budding. We will talk about the atrophy in a second, but yes, there is, of course, some degree of atrophy. I think we covered the crypt branching heavily now, and I am going to take you to another features of conicity. Yes, another features of architectural distortion, crypt architectural distortion or conicity, which is the crypt dilatation. Yes, the crypt dilatation is another feature, right? So this is here. We tend to get a lot of resections with something like that, isn't it? And what do you think? If this is a dilated crypt, or would you let it go? Right? So tell me. So what do you think? Let it go? Yes? No? So اختلفت الآراء. Okay, some of you said I will consider it crypt architectural distortion with crypt dilatation, and some of you said no, I wouldn't consider it as such. Yes? Yes, I agree with you that if you say that this is the only finding in your biopsy, again, I will let it go. But if it is present with other stuff, then I will not. But so this is on the borderline, right? It's a little bit borderline, but and if it is isolated, I will not consider it dilatation. What about that fellow? What do you think of this? Okay, do you think that this is dilated crypt? Or do you think it is not a dilated crypt? What's the verdict here in this guy? Right? So tell me. Yes, yes, we know it is branch, but my question is not about the branch. Yes, my question is about dilatation. Yes, okay. The other things, one things that you can always also use just to compare the leumina, the caliber of the leumina here and there to the surrounding crypts. Yes, because dilated crypts mean it is dilated in relation to the other crypts. Okay, so if maybe generally speaking that this mucosa tends to have a little bit of a wider crypts. Yes, so there can be a normal histological variation sometimes where you can get this idea of dilatation in the surface, and it's a phenomena that they tends to, it has got a name, but very complex. I think they call it Halcock or something. It's a phenomena. Sometimes you find it in the biopsies, but we all tend to ignore it. But the ultimate really things that you need to compare the diameter to the diameter of the crypts around it. And if you think it is more or less the same, then you can tend to ignore it. So if you compare like for like, we can ignore this and we will not consider it dilatation. The other things as well, don't commit to a dilatation which is very near to the surface, right? So this is another rule for the colitis. Why do you want to commit to a dilatation next to the surface? Yes, it is too wide. Okay, يعني it is يعني حفرة في الشارع دي. اوكي محتاجة تتغطى حط عليها warning sign، لكن it is very near to the surface، فبالتالي it doesn't really qualify you to be a dilated crypt near to the surface like this. So where the dilatation is quite important. So several rules now that you need to assess the dilatation in relationship to the biopsy, if it's an isolated finding or not, and you need to assess it in relation to the caliber and the diameter of the crypts around it, and you need to try to avoid judging it next to the surface, right? So these are simple rules, but if you forget them, then everything you will see on the biopsy, you will consider it dilatation. This is different now. Now, this story here is different. Look at this crypt here, right? It is not surface. Actually, this is at the base now, right? So the crypt dilatation is happening at the base. And look at the difference in the diameter in relation to the surrounding crypt. Look, this guy and this guy على قدهم يعني غلابة. لكن بص this one يعني ده اللي هو المتربع على واخد كل حاجة. مهم يعني هي this is dilated crypt. So this is for me is a crypt architectural distortion, right? So for me this is a crypt dilatation, and that will give you crypt architectural distortion signature to tell me that there is a feature to suggest chronicity, right? So this is another example. Look here. These are all dilated. It's not only branched. Yes, there is a complexity of the branching. There is tortuosity. We will come to the tortuous appearance in a minute. لكن the base is dilated. Look, the base of the crypt usually is narrow, and you can compare, right? Compare the caliber of the lumen here to that fellow just sitting next to him. Okay, فبالتالي then you know that there is a crypt dilatation then, yes, but this is a dilated crypt. I will come to the irregularity in a minute, but remember again, the hyperplasia is a feature that's limited in the lower GI to a certain condition, right? Like we don't really use the word hyperplasia unless if you see a proper serrated morphology. So if I am to judge all these crypts, I would say there is serration here in this area, slightly serrated, yes, and here serrated, okay. Lekin in a serrated hyperplastic morphology, you don't get a dilated crypt unless if you are dealing with a serrated adenoma. Yes, you can get it at the base of the crypt, you get dilatation at the base. Lekin this is not an adenoma. Yes, all the biopsies that I'm showing it today for you are from inflammatory bowel disease, right? So don't mix the serrated adenoma with this, because we are just talking about inflammatory bowel disease today. Yes, so yes, you are right, Dr. Farah, it looks like a serrated adenoma, لكن طبعا السرration بيبقى أعلى كتير بالنسبة للserrated adenoma. It doesn't just look like this. It looks more complex. في يوم من الأيام we will cover it, and I will show you good examples of serrated adenoma, and you'll understand why it is different from this. Like in here, we have complexity of branching, we have tortuosity, but we have dilatation. And I showed you that fellow here alone. That fellow here is a dilated crypt, because you compare it to the other three, it is nearly الليومنا بتاعته حوالي 5 times bigger than the other lumina. فبالتالي we can accept this as a dilated crypt. Yes, okay. So that's absolutely fine. And this is just to show you, again, this is not only dilated at the surface. If it was only at the surface, I would have let it go. But it is also dilated toward the lower part of the crypts. As you go deeper and deeper, you started to see the dilatation is continuing. So this is different from the example which we discussed before. Another close up on the same view to show you some evidence of this. But I just wanted to take you to another good example of that. Here we go. Now then, do you think that this is a crypt dilatation or not? What do you think? What do you think? Right? So tell me. Anyone? No. 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 Okay. Yes, you see now you started to compare all the crypts against each other. Although you have some lumina that is quite open and it's closer to the base here, لكن في نفس الوقت it isn't really a crypt dilatation, because when you look into all the crypts around it, you can see that the caliber is okay. Yes, there is a branching, yes, but I'm just targeting the dilatation for now, right? Here, what do you think? Would you call this dilatation for this fellow? What do you think of this? Yeah, okay. So no, because you see, يمكن yes, 1.5 times than the average caliber of the surrounding crypts, but we can definitely not consider this as a dilatation, and don't look at the surface and consider it as a dilatation here, and we will come to this in a minute. Okay, so this dilatation, so remember the rules of dilatation. Let's go to the horizontal and oblique crypt alignment. Okay, this is another feature that you should look at it in isolation in order to judge the crypt architectural distortion, horizontal and oblique crypt alignment. Let's see the normal pattern or near normal pattern or mild inflammatory pattern, whatever you wanted to call it for now. I will accept this for now only, that you tend to get all the crypts are vertical. Yes, so they are all going in one direction. If you have a nicely orientated biopsy or a nicely orientated mucosa in this, and when you take the crosscut on the side, on your left side, you get these donuts, which are kind of very regular in shape, and they are very close to each other. This is the normal. I'm not going to teach you normal, but I just wanted to show you the alignment next to each other of what we will call it vertical alignment in both of them. And the test tube, as you know, as Dr. Ayman mentioned, you are absolutely correct, the test tube pattern of alignment, okay? So, okay, I just wanted to show you this. This was a, I think, a Crohn's disease case, and all what we saw in this was this branching. You see, you cannot ignore it, right? When you start to see them happening frequently and they are happening quite deep, you can't just keep a close eye on them and say, well, I did not see them. They are there. I just drawing them. So this is absolutely fine. Now, the question if it is touching mucosa or not depends where it is from, isn't it? Because the crypts can be a little bit shorter. It depends which side of the bowel, isn't it? In the right side or in the left side, because you can get slightly shorter crypts. So we cannot judge unless if we know the shortening, if it is definitely the site where you can assess the crypt art, this idea. But what I wanted now to show you, I wanted to show you the oblique alignment of the crypts. Look, this crypt is not harmonizing with the mucosa. Look, the mucosa is here. You would expect the crypts to go down like in that direction of that crypts, yes? But look at this. This is now taking an oblique direction, which is a feature that I would not, I will consider it as an architectural distortion. You can see it here, you can see it there. And when we go to the other surface, because this was slightly polypoidal, you can also see this here. That direction is wrong, right? So I'm not talking still about the parallelism. I'm talking about the isolated crypt direction. Yes. So just even here, you would expect the crypts to go down that way. However, that one is trying to kink. That one is kinking more, but this one is forming an angle. This is what you call it angulated crypts. This is different from the oblique and horizontal alignment. This has got like a 90-degree angle here, which we can measure it زي ما كنا بندرس في حساب مثلثات زمان. Yes, so this is 90-degree angle. This is an angulated crypt, but this one is an oblique alignment, and here is a kind of like horizontal alignment of the crypt. It is like trying to be parallel to the surface. Okay, it is not parallel to other crypts. It's trying to become parallel to the surface, and that is one thing to see here. You can see this. Okay, يعني هو يعني ايه اقعد بيقول لك ايه اقف عوج وكلمني مظبوط. والله ما فاكر مش فاكر الجمله غالبا كانوا بيقولوها كده. المهم يعني اوكي، فهي بصي يعني هو الكبت مايل حاله مايل. بصي عايز ماشي عايز يمشي في اتجاه اخر خالص غير الاتجاه المفروض انه كان يمشي فيه. هو ideally it should have been going that way, and look at this. This is trying to become parallel to the surface. It's trying to be parallel to the surface here. So this is an oblique crypt. This is a horizontal alignment of crypt. The problem here that this change of directions, sometimes it is dragged by the atrophy, of course, sometimes it's dragged by fibrosis, as you correctly said, Dr. Asma. Sometimes it's dragged by only inflammatory cell infiltrate that's pushing. You see, for example, here, in this case, even when I am not opening my eye, I don't know what diagnosis of every case, but if I am to give a diagnosis, would you go for infectious cause, ulcerative colitis, or Crohn's disease? What would you go for? Yes? Okay. So some of you said ulcerative colitis. Do we agree with this? Do we agree or we don't agree? Transmural. Okay, absolutely. Yes. So don't forget that even in a small biopsy, you don't need the resection to tell you, but you can see the muscularis mucosa has got inflammation and the submucosa has inflammation. Okay, عشان خاطر الناس اللي هي بتقول لكم على طول دايما الكرونز ديسيز ما فيش فيه architectural distortion. طب اهو فيه بقى. اهو قدامكم. اوكي، واللي عايش ما يشوف اهو قدامكم. Of course, this is what we call a fulminant colitis in Crohn's disease, and this is when it becomes tricky to differentiate between the two. I think we reached the time. I think we have to stop لأن طبعا يعني الناس خلاص تعبانة ونايمة. So I think we have to stop. I think it might have come as a surprise. It's basic. I know it is very basic lecture. لكن I think this is what people don't explain. They just don't tell you. As I told you, they give you the list and they don't tell you what is behind that list. But at the moment, we will see more and more and more, and we will be able to really read these little biopsies, and then you will know why you need to commit. And this is what will happen. يعني الله يفتح عليكم بالعلم ويثبته في عقولكم وقلوبكم ويفيد بيكم ناسكم واهليكم ومرضاكم. and دايما بوصيكم يعني خيركم من تعلم العلم وعلمه. فبالتالي you have to transfer all what we share here to your other colleagues who did not get a chance to attend, and I hope that you find that useful today. And يعني we didn't touch any diagnosis except in the last slides, but I just wanted to show you why people get it wrong. حتى يعني أساتذتنا وعلى راسنا من فوق by why they do get it wrong, and it is as simple as that. You just have to, it is always going back to the basics. يعني إن شاء الله بإذن الله هنكمل في المرة القادمة. ويعني شكرا كتير على وجودكم معانا النهارده والله يفتح عليكم، وإن شاء الله بإذن الله يعني تكونوا استفدتم ويكون استفادة عامة بإذن الله. وكل سنة وأنتم طيبين، والسلام عليكم ورحمة الله وبركاته.